Meniscal lesions are going to be determined based on different classifications of direction, extent, and blood supply to the area. If we talk about direction, they will occur based on different mechanism of injury. For example, a longitudinal tear is usually going to be a twisting motion when the foot and knee are flexed. Horizontal tears are more likely to occur because of a degeneration in the meniscus. If a person has a vertical or a bucket handle tear, they're going to notice locking of their knee. If someone happens to have a discoid meniscus, they have an abnormally shaped meniscus. These people tend to be asymptomatic because this is a congenital problem. The most common meniscus that will be affected by this discoid is the lateral meniscus, and we will often call this poppy knee syndrome. We also may see something called a parrot beak, and with a parrot beak tear, this is something where you'll see an adolescent athlete or patient that have had previous injuries to their meniscus. The second classification is the extent, and that simply is it an incomplete, a complete, or a complex tear. Then there is the blood supply. There are three different types of blood supply areas in the meniscus. The most outer area is the red to red. These are vascular tears and therefore they are repairable. The red to white are transverse tears, and this is kind of a gray area. It kind of depends on the surgeon. And finally, there's white to white. These are avascular tears. Usually, if someone has damage to the white to white area, that tear is going to be excised. The menisci do not have great blood supply regardless, and so even though it's a red to red, that does not promise that that is going to heal after a surgery. People with meniscal lesions are going to complain of catching sensation or mechanical block during knee movement. There will be joint effusion. In the case of an acute injury, it can be tested with a bilateral patella test, showing that the swelling is intracapsular. In more chronic type lesions, there will be minimal swelling. Depending on which meniscus is involved, there will be medial or lateral joint line pain. The individual will be dysfunctional with closed kinetic chain cutting, and they will avoid deep knee squats or seated leg cross because of the pain that it causes. In acute cases, the range of motion is limited by joint effusion of the meniscus in the joint line. In chronic cases, you may notice a springy block during the passive range of motion. There are many, many special tests for the meniscus, including the McMurray's test, which will be done in two different directions, including flexion of the hip, internal rotation of the foot, and an external rotation of the hip, and then reversing that, where you externally rotate the foot and internally rotate the hip. The Apley's compression test involves putting pressure on the knee and recreating that pain. The Apley's distraction test can be done as well. If pain is produced during compression, that is indicative of meniscal lesions. A bounce home test can happen. The EG test, this one has a person externally rotating leg for the medial meniscus and internally rotating the legs for the lateral meniscus, and then squatting and standing up. And then finally, the Thessaly test. The Thessaly test includes a twisting motion at both 5 and about 25 degrees of flexion. The Childress test can also be done. This is just to see if the person can do a duck walk. If you look at our chart here, we can see that probably the best tests that you can do for meniscal lesions are the Thessalys at 5 degrees and 20 degrees. With chronic meniscal lesions, your quad and ham will atrophy, especially the VMO, though you will not see a change in range of motion so much. Diagnosis is generally going to be with the MRI. This is the non-surgical gold standard. It generally has about 80 to 93% sensitivity. If we're going to go surgically, an arthroscopic surgery will generally have a 90 to 95% sensitivity. The previous gold standard of an arthrogram, which is an injection of dye into the area, is not done very often anymore. Treatment for meniscal lesions is very difficult. The general rule is to preserve the meniscus as much as possible to minimize degenerative joint disease. If we try to wait for meniscal healing, we have to keep in mind that in adults, only the peripheral 20 to 30% is vascular. So depending on the extent of the tear, it may not all receive blood vascularization. In meniscal repairs, we might do a repair if it's about 1 centimeter in length within the vascular zone. Meniscal transplantation has been done, although that is not always that successful. And there's also meniscectomies, and people may have a partial meniscectomy or they may have a full. Many people may choose to do the meniscectomy over the actual repair because it will allow them to return to activity much sooner, 10 days versus 6 weeks with the surgery.